Hi, everyone, and welcome to the changing role of PARP inhibitors in the treatment of ovarian cancer. I'm Stephanie Blafarb. I'm the Ovarian Cancer Program Director at SHARE. Before the presentation begins, I'd like to tell you a little bit about SHARE. SHARE is a nonprofit organization that for the last 40 years has been helping people through breast or ovarian cancer, offering the support of those who've been there. SHARE offers many services, including a helpline, telephone and in-person support groups, educational programs, and more. All services are free of charge to participants. For more information, visit our website at sharecancersupport.org. So during this presentation, all participants are muted. When the presenter finishes speaking, we will open up for question and answers. Already many of you have submitted questions, but you can still submit questions throughout the presentation by clicking on the question pane and entering your questions there. And I'll be taking those and asking those at the end of the presentation. When asking questions, remember the presenter is unable to give specific medical advice, so please keep your questions general in nature. This webinar is being recorded and will be available on the SHARE website soon. Now I'd like to introduce our speaker today. Dr. Kathleen Moore is an Associate Professor of Gynecologic Oncology at Stephenson Cancer Center, where she also serves as the Associate Director of Clinical Research and the Medical Director of the Clinical Trials Office. She is also the Principal Investigator of the SOLO-1 trial. Dr. Moore has published more than 200 peer-reviewed publications and serves on the editorial board for 4 academic publications. She is a board-certified OBGYN and a gynecologic oncologist. She's also certified in hospice and palliative care and holds a master's degree in epidemiology. Her main research interests are in drug development and especially phase 1 trials. So thank you for joining us, Dr. Moore, and go ahead and tell us more about PARP inhibitors.
Great. Thanks, and thank you for having me. I'm happy to be here. And you can see my slides, okay?
Yeah.
Okay, perfect. So what I'm going to take us through today a little bit quickly is sort of what we know right now about how to treat women with ovarian cancer in the first treatment, and then how we treat patients who have recurred, and how PARP inhibitors fit into that treatment paradigm, which is a sort of a rapidly changing story. It seems like once a month it changes, but as of today, where we think PARP inhibitors fit. So this is just one of many sorts of schemas that I could show that just gives the unfortunate truth of the typical course of advanced ovarian cancer. Patients present usually with disease that is stage 3 or 4. That's the norm. 80% of patients present in that stage because we just don't have good ways of screening. We treat it with a combination of surgery and chemotherapy that we call platinum-based chemotherapy with cisplatin or carboplatin. And usually, not all the time, but usually the ovarian cancer is really exquisitely chemosensitive. And so with that combination of therapies, you'll see about 80% or even a little bit higher sometimes of women have a complete response to that first therapy, which means that when you look at their CAT scan and you look at the blood marker, which is a CA-125, it all looks relatively normal at the end of 6 to 8 cycles of chemotherapy. The standard of care until very recently in the United States, once you got to that point, was to put someone in what's called active surveillance, where we would see patients back every 3 months and do a CA-125 and an exam, and sooner if patients had symptoms and called us, and we would keep an eye on them in that way for 2 years, and then at the 2-year mark, we'd extend to every 6-month visits, although a lot of my patients don't like that, and so I still see them every 3 months. And we keep an eye on folks, really sort of waiting for the inevitable, which is that these cancers come back. There's about 15% of women in whom it never comes back, and we're very interested in studying those women to figure out why that is, that it never comes back, even though they got the same therapy as everyone else. But really, for the vast majority of patients, recurrence is not surprising, and it can happen along a spectrum of time. from very soon after the completion of chemotherapy to years later. And and we'll talk about this a little bit more, but the time to the recurrence, and then the type of cancer, the cell type of cancer that one has, the molecular characteristics of the cancer, like BRCA status, et cetera, all play into what options we may offer a woman who has recurrent disease. And then there's a series of therapies that are offered once recurred, really for much of the remainder of a woman's life. And so what we say is that if we're going to impact really greatly on ovarian cancer, it's going to be in the first line. If we convert more patients to cures, then that's really how we're going to impact on this disease, and that's what we're trying to do. This is sort of just another way of looking at it. This is what we call a Kaplan-Meier survival curve. Can you see my arrow, or my pointer? Hopefully. So what we know in first-line chemo, about 20% of patients who got surgery and chemotherapy and everything was done appropriately for whatever reason, they recur very quickly within 6 months of completing chemotherapy. And that's a group of patients for whom we don't really retreat with platinum. We go to other sorts of therapies. Then you have another 22% of patients who recur between 6 and 12 months. And then there's another 30% of patients who recur between a year and 5 years. And then there's about 20% of patients who at 5 years still have not recurred. By about 10 years, that drops to the 15% number that I talked to you about. So this is sort of the breakdown of when we're following somebody with ovarian cancer, what we expect. What we've learned over time is that ovarian cancer, even though overall it's rare, there's about 22,000 cases in the United States each year, which sounds like a lot, but it's, if you think about breast cancer where there's 250,000, it's really a rare tumor. So in the past, when I was training, anyone with any kind of ovary cancer could be enrolled on a clinical trial for ovary cancer, for example. What we understand now is that was probably a little bit silly, because we understand now that ovarian cancer is actually a number of different diseases. There's this breakdown of epithelial and non-epithelial. We're not going to really be talking about the non-epithelials today. We're talking about epithelial, the most common of which is high-grade serous, but then there's low-grade serous, mucinous, clear cell, and endometrioid. And these tumors are actually very different molecularly. So you can just see, and I know this is a lot of detail, but in high-grade serous, these are driven by loss of the tumor suppressor gene TP53. They can be characterized by mutations in BRCA1 and 2, and they have a slew of other abnormalities that can be seen when we look at the tumors. Low-grade serous cancers are entirely different. They have entirely different molecular pathways, which makes us think differently about treating them. Not entirely, but we do use some different things. Mucinous cancers are totally different, just a completely different cancer, as are clear cell. So these are really different cellular types that warrant different approaches for therapy, and we're really trying to figure that out now, so that we're not just giving everyone the same thing, which is Paclitaxel and Carboplatin. That's been our standard of care for forever, and we're just starting to kind of eke out of that and try and individualize the therapies that we use for patients based on their cell type and the molecular characterization of their tumor. So when we operate on someone, there's the decision of whether or not we do it first or if we do it in the middle of chemotherapy, and there's a lot of controversy about that. I don't know that we want to get this would go way down the rabbit hole, but there's a lot of controversy about this. But there are those who believe that you should operate first before chemotherapy and do a very radical surgery to remove everything that you can see and then give chemotherapy. And retrospective studies would support that, in that those retrospective studies, meaning when you look backwards in time, patients seem to do better if they have surgery first. There is, though, now prospective studies where we've actually enrolled women on clinical trials and followed them forward, where we compare those two approaches. And there does not seem to be a difference between operating at the beginning or operating in the middle. And that's been shown in now 4 big clinical trials across the world, with no differences in outcome for women, but in terms of how long they live, but a big difference in safety. Is operating in the middle of chemotherapy, the surgeries tend to be less radical, and so less complicated. And so this is still controversial. Again, I think we could spend an hour talking about surgery. I think there's shades of gray in which timing you select for a person. There's individualization, but there's a lot more acceptance of doing this sort of neoadjuvant approach now, where you start with chemo, shrink the tumor, remove it in a slightly easier surgery. It's still a harder surgery, and then kind of mop up the rest with chemotherapy at the end. The standard of care chemotherapy is Paclitaxel and Carboplatin. We've tried all sorts of things, like giving the Paclitaxel every week, putting the Carboplatin or the cisplatin in the belly. That's intraperitoneal chemotherapy. We've tried all sorts of things trying to improve upon this. This was a very recent study called ICON-8, which compared every 21-day Paclitaxel Carboplatin to using weekly versions, which was thought to be better based on the breast cancer literature, and it really showed no difference in outcomes for women. And so, weekly Taxol can cause more neuropathy than the every 21 days. So I think this really gives us permission to use the every 21 day and not feel like we're kind of shorting our patients their best chance, because it looks exactly the same. Those curves aren't any different from one another. So this was a very important study in terms of really bringing every 21-day Paclitaxel Carboplatin kind of back to the preferred regimen. It's more convenient for patients and it's less toxic than weekly. So again, there may be individualization in certain situations where you think weekly is better for your patient, but certainly every 21 day is not inferior at all. So this was an important study that was presented just in 2017 and really changed practice for a lot of us. Then there's the question of whether or not to add something to the first chemotherapy, and that's something until very recently was a drug called Bevacizumab. You all may know it as Avastin. This is a drug that targets how tumors make blood vessels for themselves to feed the tumor. And so we can block at least one mechanism of that with Avastin. And we know ovarian cancer is really driven by this concept called angiogenesis, which is blood vessel formation. And so Bevacizumab blocks a key element of that process and is a very active drug in ovary cancer. So it was tested with every 21-day Paclitaxel Carboplatin and continued as a maintenance therapy of just Avastin alone for a year to follow. And this was done in the United States, that's GOG-218, and in Europe, that's ICON-7, with very consistent results where it improved or prolonged the time to the next progression. So in Europe, this became the standard of care very quickly. In the United States, this was just recently approved in late 2018. So while some patients were getting frontline Bevacizumab added if their insurances were covered, would cover it, most patients could not access this. It's an incredibly expensive drug, but now it's FDA approved, and so its use in frontline chemotherapy and to follow is picking up. We don't really see a benefit in overall survival with Bevacizumab, so it just seems to be a benefit to the time to first recurrence, but we don't see a detriment in overall survival either, which is an important feature. So Bevacizumab is certainly, or Avastin is certainly here and now in frontline treatment for ovarian cancer, and is an option. Do I think it's a necessity? Not necessarily. I talk to my patients about it, but it is certainly an option, and it does have a positive impact on their, what we call their progression-free survival, or the time to first progression, and prolonging that. So there's a lot of unmet needs. If you think that's where we are with newly diagnosed ovarian cancer, we have a lot of work to do really in anything we do in maintaining quality of life and making our regimens as tolerable as possible. But really the big thing is, curing more patients in the front line so we don't have to worry about all these issues at the time of recurrence. Really improving that 15% to be a much higher number so that we just have fewer patients that have recurrences. And then there's a lot of other kind of things to think about, how we treat patients who are older, how we treat patients who maybe are very, very sick when they present. How do we adjust therapy for them so we can get them the best outcomes possible? There's lots of things we're thinking about, but really how we cure more women is the most important. The second most important thing, the first most important thing is how do we prevent this to begin with. So that's frontline, and I'll come back around to that. We're not quite to cure yet, so we still have patients who progress. And at the time of progression, again, this is sort of just a general timeline. What you see is that patients have this time after frontline chemotherapy, and then they'll start to have some symptoms, and usually patients know their bodies, so they recognize things much earlier, and they come in like saying something is wrong, or we see a bump in their CA-125. They'll get treated again. The time to the next recurrence will come quicker, unfortunately. And so then you see these timelines between each subsequent line of therapy get a little bit shorter and shorter as the tumors become more and more resistant to chemotherapy. And this is just the unfortunate reality with ovarian cancer, is that when you expose it's like an antibiotic. When you expose it to chemotherapy, it figures out how to be resistant. And so each time you expose it to something, it's smart and it figures out how to get around that. And then that chemotherapy may not be useful in the future. And so these are the challenges to us for improving outcomes. So when we have patients who relapse and we think that carboplatin is still a good therapy for them, we tend to use carboplatin again with a partner. And that partner could be Paclitaxel again, or it could be a drug called Doxil, pegylated liposomal doxorubicin. Doxil is easier to say, or gemcitabine. And these are the studies that showed any of those doublets, as we call them, is an effective therapy in prolonging, again, the progression-free survival, the time to the next recurrence, but not really so much overall survival, which is a bit disappointing. And we think all of those different doublets are about the same in terms of how effective they are. We tend to like carboplatin and Doxil a little bit better because it's only every 4 weeks, and it looked a smidgen better than Carboplatin in the study. Not overwhelmingly so, but if you ask most people, they like Carbodoxil as the first recurrent selection. And so that tends to be what people use, and you can use that with Bevacizumab. Here at the bottom of this table, you can see the two studies that took, this predated the data for carboplatin and Doxil. So it was carboplatin and gemcitabine or carboplatin and Paclitaxel. And just like that frontline study I showed you, added Bevacizumab with chemo and to follow as a maintenance. Here, though, the maintenance is continued indefinitely until such time as progression. Frontline, we just use it for a year and stop, which may not be the right thing. But in recurrence, we use it until patients recur again. So sometimes patients could be on Bevacizumab for a long period of time, and it holds the disease recurrence off, sometimes for a very long period of time. So here it was a very effective addition to chemotherapy. And this has been FDA approved for many, many years. This is just showing you the differences in the survival curves for use of Bevacizumab versus no Bevacizumab. So you can kind of see that the patients who are on this curve or this curve, the purple curves, who received chemotherapy with Bevacizumab, they go for a longer period of time before they recur than the patients who did not receive Bevacizumab. So this is what prompted approval of Bevacizumab in this setting in the United States and in Europe. If you recur with your disease and platinum is not an option for you, like if you recur very quickly after receiving carboplatin, then this is the list of drugs that we use instead of platinum. And again, bevacizumab here is very important. So this is bevacizumab again plus chemo, and it can be any chemo, weekly Taxol or Doxil or a drug called topotecan. We don't really like topotecan very much, but we like weekly Taxol and Doxil. And again, you can see in purple the patients who received bevacizumab and chemo versus those that got chemo alone went twice as long on their therapy as those who didn't receive bevacizumab. So this was actually the first approval for bevacizumab in ovarian cancer, was in this setting of patients for whom platinum isn't a good option. And sometimes those diseases are very hard to treat. This really made a very meaningful impact on progression-free survival for our patients, and really is the standard of care. And then this just breaks down the different options. This is Paclitaxel, topotecan, and Doxil. And the benefit really is very similar in any of the types of chemotherapy. So we individualize what chemotherapy we pick based on prior toxicities. Like if someone has really terrible neuropathy, we may not use Paclitaxel again, we may use Doxil. So we pick the chemo sort of based on how someone's feeling and what their residual toxicities are from their first therapy. BRCA testing has always been important, but we just were not good at it in the United States. Currently, we're testing about 30% of patients, so I think that's about to skyrocket with recent PARP approvals. But testing BRCA is incredibly important for all women with epithelial ovarian cancer. There's no triage, like by age or family history. If you have ovarian cancer, then you should be tested for, or at least offered testing for BRCA. And we typically do this with what's called a germline test, meaning we test like your saliva or blood, and we're looking for a mutation that you're born with. The other way we can do it is we test your tumor, and we look for a lot of mutations in that setting, inclusive of BRCA, and that will pick up germline. So if you're born with a BRCA mutation, you're going to find it in your tumor. But also about 7% of women with ovarian cancer have a BRCA mutation only in their tumor. Like they weren't born with the mutation, there's no risk to their family, but it's in their tumor, and it's just as important from a treatment standpoint as being born with BRCA in terms of response to PARP inhibitors. So we pick up those women if we do a tumor test. So right now, I think we're trying to figure out which is the best way to start someone off. Do we test everybody with both? Do we start with a tumor test? And if that's entirely negative, then you don't need a germline test. That kind of makes sense, although you can miss about 4% of germline patients with just a tumor test. There's pluses and minuses to doing either one alone. But I think if we got to a point where everyone were being tested with at least one of them, then we'd be doing a million times better than we are right now. So we need to get everybody tested. It has impact on the therapies that we pick for patients. And if you have a germline mutation, it allows us to counsel family members and offer them testing so that we can prevent breast, ovary, pancreas, ureteral, there's some other cancers as well, because we can screen for those cancers and prevent them in children, siblings, first and second degree relatives, which is really what we want to do. That's called cascade testing. And then we can do risk reducing surgeries at the appropriate time so that people don't even develop these cancers. So that's the most important reason to test, but now it also impacts therapy. So this is just what I said. For testing, everybody who has epithelial ovarian cancer at the time of diagnosis should be tested. It doesn't have to be the day you're diagnosed, but should be early on because you don't want to forget about it. It gives us prognostic information. It right now helps us select therapies, and it's very important for what we call cascade testing, which is testing of family members. But in terms of therapies, what we're thinking about and what we're talking about are PARP inhibitors. So this is just a little cartoon to explain how PARP inhibitors work. So PARP is poly-ADP ribose polymerase, which you do not have to remember. You just remember PARP. But PARP is a very important protein involved in fixing DNA. So if your tumor has, or your cells have a single strand break in their DNA, which happens all the time because our cells are always replicating, then PARP comes to that site and lands on it. So there's a PARP inhibitor. PARP comes and lands on it and recruits DNA repair proteins so they can fix the DNA, and then the cell keeps living. So if you inhibit this with a PARP inhibitor, which is what you see in orange, that then traps the PARP protein on the DNA, which is not a good thing. And if you trap PARP on the DNA, it causes double-strand breaks. It can't fix the single-strand break. It leads to double-strand breaks in cells that are replicating, which is what tumor cells do. And so if you have a cancer cell, and this says HRR deficient, so that means homologous recombination repair deficient. So that's repair of double-strand breaks. So if your cell has a BRCA mutation or other mutations, BRIP1, RAD51C, there's a slew of them that lead to this loss of ability to fix those double-strand breaks. So if you don't have that, and you have a PARP inhibitor, then your cell dies. If your cell can fix its double-strand breaks, and I give you a PARP inhibitor, then the cell just fixes itself and the PARP inhibitor doesn't work. So we really want to identify those patients whose tumors can't fix their DNA. And that's patients with BRCA mutations, but it's also other patients as well. And so this pie chart shows you that. So you have your BRCA mutations up here. It's about 25% of ovary cancer. But then all of these other mutations also lead to a cell that can't fix its DNA. And so these are cells that are susceptible to PARP inhibition. So about half, a little over half of patients with ovarian cancer will be sensitive to PARP inhibitors. So we're trying to increasingly identify not just our BRCA patients, but others as well, so they can get the benefit of a PARP inhibitor. So, why? Why are PARP inhibitors of interest, especially for BRCA patients? Well, because they work, and they work really well in kind of all patients, but they work really, really well in BRCA patients. So we have 3 on the market: Olaparib, Niraparib, and Rucaparib. They're all approved for treatment of patients who've recurred and have gotten Carboplatin plus whatever again and responded. So they got 6 or 8 cycles or whatever, the disease got better, and then they go on to a PARP inhibitor as a maintenance, again, just like Avastin or Bevacizumab, until the time of recurrence. So all 3 of them are approved for that in all comers, and I'll show you why that is, not just BRCA patients. Olaparib is approved in frontline maintenance, and I'll show you the data for that. That just happened. And then Olaparib and Rucaparib are approved for patients who have BRCA mutations just as treatment alone. So you don't have to get chemo and then the PARP. You can just use it instead of chemo in certain situations. So the reason why these are approved comes from a series of studies that I'll go through relatively quickly, but this was the first one. This is the NOVA study, which was Niraparib, and it randomized patients who had recurrent disease. They responded to platinum-based therapy again, had a good response, and then they were randomized to get Niraparib, which is a PARP inhibitor, or placebo. And there were 2 big cohorts. One had BRCA patients, and the other were people that did not have, women that did not have a BRCA mutation. So they looked at them in these 2 separate cohorts. But what they found, so here's your patients who have BRCA mutations. Here's their progression-free survival curve. So, and then here's the patients who got placebo after induction treatment with chemo in the recurrent setting. The patients who got PARP inhibitor did markedly better. They went almost 2 years before they recurred on the average. So you can see the median or the average time to the next recurrence is 21 months. That's the average. So half patients went longer than that, as compared to only 5.5 months for patients that did not get a PARP inhibitor. So that results in what's called a hazard ratio right here of 0.27. So how you interpret that is that tells you that use of the PARP inhibitor Niraparib reduced the risk of recurrence by 73%. So that's a big reduction. So it's clearly an active drug. But even in the non-BRCA patients, you still saw a significant benefit to doing nothing, which was the old standard of care. Or you could use Bevacizumab. That was kind of your option. So here again, you see a hazard ratio of 0.45, which means you have a 55% reduction in the risk of progression. So it's not as much as with a BRCA population, but still really pretty good. And so that's why the FDA approved use of Niraparib for anybody with ovarian cancer who has recurred and gotten a platinum again, and the disease had a good response, because that's a marker of responsive disease, and then they can get a PARP inhibitor. So that was the Niraparib story. Similar is Rucaparib. So this was studied in a study called ARIEL-3. It was a little different design. They had one randomization to Rucaparib or placebo, and they just included everybody, BRCA or non-BRCA, in one study, but they looked at them separately kind of throughout the studies. Their statistical analysis was a little bit different, but you get an idea of the same sort of idea here, where if you look at the patients who had a BRCA mutation, this is their patients who got Rucaparib, this is the patients who got placebo. The numbers look very similar to what I just showed you, with the average time to next recurrence of 27 months versus 5.5 months. So that 5.5 months looks very consistent with the NOVA study, and a hazard ratio of 0.23. So a 77% reduction in the risk of progression. Very consistent with the BRCA group in the NOVA study here in ARIEL-3. So that's reassuring. Then they looked at patients who did not have this is where it gets a little bit confusing. This graph has the patients who have BRCA mutations, and it includes now the patients who do not have BRCA mutations, but on that pie chart I showed you, there was all those patients who had other mutations that made their tumors unable to fix their DNA. This includes all of them, so all in one. So here you can see that the hazard ratio is 0.32, so 68% reduction in risk of progression. And then they looked at patients, the whole group, so inclusive of the BRCA patients, patients who can't fix their DNA, and patients whose tumors could fix their DNA, who we would expect to respond least well to PARP inhibitors. But again, you see this positive trend with use of a PARP inhibitor. So just like NOVA, Niraparib, the FDA said Rucaparib can be approved for all comers. You don't have to have a BRCA mutation. So I'm going to skip this one and show you the last study, which is SOLO-2. So this is Olaparib, same design, recurrent disease, got a platinum, responded. Here, only patients with BRCA mutations were included. So this is a little bit different in that it was a little more restrictive, and they got Olaparib or placebo, but very consistent results in terms of the hazard ratio 0.3, so a 70% reduction in the risk of recurrence. And then you can see the average time to recurrence was about 20 months versus, again, 5.5 months. That's very consistent in the placebo arm. And so these three studies all led to the approval of PARP inhibitors as maintenance following platinum-based chemotherapy for patients who had recurred. And that happened starting in 2017 to now. So 2017 and 2018 is where we saw the emergence of this approval in this setting. I just put this here, and this is true really across the board, that PARP inhibitors do have side effects, and we can talk about that at the end if you all have questions. They have to be discussed up front so that patients have very good expectations about what it means to be on a PARP inhibitor, and they can sort of self-regulate their symptoms at home. But in general, they are well tolerated in the majority of patients. In fact, 70% of patients on SOLO-2, just as an example, stayed on their starting dose of Olaparib throughout their time on trial. So in other words, they didn't need a dose reduction due to toxicity. And they didn't discontinue due to toxicity very often, only about 10% of the time. So that tells us that the drug is relatively well tolerated. Doesn't mean it's without toxicities, but there are toxicities that patients felt were reasonable. And that is demonstrated, I think I still have this here, that's demonstrated here because we're very interested in developing drugs that work, but also don't make people feel terrible. That's not a great trade-off. So one of the analyses that was done in SOLO2, and it's actually been done in all of the PARP studies, is something called the Q-twist. So this is time without symptoms or toxicity. So basically you pick the toxicities that you think are most important. So for this one, the toxicities that were picked were fatigue, nausea, and vomiting. Those were the three big ones. And this is the survival curve I showed you for patients who got Olaparib. This is the survival curve for patients who got placebo. This is the dark bars here and here is the amount of time that patients reported having grade 2 or higher nausea, vomiting, or fatigue. And they were asked throughout the study to do patient-reported outcomes and tell us how they were feeling and for how many days. And so you basically take that time with that significant toxicity and you subtract it out of the total area under the curve, the time that you gain from using the drug. And this is placebo. So if this had been this huge amount of this curve, say, then you would say, well, great, I improved progression-free survival hugely, but patients felt terrible 80% of the time. So is that really worth doing? We didn't see that here. Even when you subtract out this amount of time from the area under the curve, this is still a statistically significantly improved quality-adjusted progression-free survival with Olaparib as compared to placebo. So hopefully that makes sense. It's not a perfect way of measuring how patients feel on a drug, but it's one of probably the better ways of really showing in a diagram patient-reported toxicities, what the patients say about how the drug makes them feel. So that's the recurrent story. So right now in recurrent disease, we do platinum-based chemotherapy with Bevacizumab and Bevacizumab maintenance, or you do platinum-based chemotherapy, you get a response, and then you do what's called switch maintenance, where you switch them to a new drug, which is the PARP inhibitor. And in both maintenances, you continue it until disease progression. Flipping back to Frontline, where I talked to you about Bevacizumab and how that was recently approved in the Frontline. So that's here. What about PARP inhibitor, a first therapy? Will that cure more patients? So there's a lot of studies studying PARP inhibitor incorporation into first chemotherapy. The first of them that reported out last year at ESMO was SOLO1. And I had the privilege of presenting this study. So in SOLO1, what we did is we had patients who had a BRCA mutation, they had advanced stage ovary cancer, they had surgery, either neoadjuvant or primary, and they, at the end of chemotherapy, had to be either in a complete or partial response, which most patients are. And they're random, and they got their chemotherapy, and then they were randomized to Olaparib for 2 years, or placebo for 2 years, shorter, of course, if they recurred, in a 2-to-1 fashion. So we only treated to 2 years. The primary endpoint was progression-free survival, which is the time until patients recurred, and then secondary endpoints were what we call progression-free survival 2. So in patients who recurred and then got another therapy, how did they do? Like, did use of Olaparib in the Frontline mean that they did worse when they recurred and got another therapy? That's an important endpoint. We're looking at overall survival and then patient-reported outcomes. And not everything has been reported yet, but progression-free survival was reported. So this these survival curves really are unprecedented in ovarian cancer. We've never seen a survival curve like this where it flattens. So at 41 months of follow-up, half of the patients on the Olaparib arm had not yet recurred. So we don't actually even have a median progression-free survival to report, but it's about 49 months on estimate, as compared to 13 months for the placebo group. So remember, this is measured from the end of chemotherapy until someone recurs. So in the placebo group, they went about a year on average from the end of chemotherapy. And if they got Olaparib, we're still following patients, but this curve has flattened. So we're not seeing as many events. And so the hope here is that some of these patients are cured. So we'll see with longer follow-up, but that's certainly what we hope. I want to point a couple things out. Here, these are all patients with BRCA mutations, which are our best prognosis group of patients. And they all got good surgeries. They were taken care of by expert physicians. And still, at 6 months, 20% of them have already recurred. So why is that happening? We don't see that on the Olaparib arm. So we're very interested in trying to figure out why this is happening to patients. Why are they recurring so quickly? And can we prevent that? And maybe we prevent it with Olaparib. And by a year, 50% of patients have recurred. So it clearly demonstrates the need for maintenance therapy. And really, in my mind, if you have a BRCA mutation, I almost feel like it's unethical to not offer patients PARP inhibitor maintenance now. I don't think a patient may opt to not take Olaparib, and that's certainly her choice because it's shared decision making, but everyone should be offered. This is the standard of care, and the benefit that it provides is just unprecedented. We've never improved progression-free survival by 3 years. We've never improved progression-free survival by 1 year, much less 3 years over placebo. So this is a very important study and definitely immediately changed the standard of care for patients with BRCA-mutated ovarian cancer. These are what we call landmark analyses, so we can show you the percentages of patients who are still disease-free at each time point. So at 36 months, 60% of patients on Olaparib are still disease-free, as compared to only about a quarter of patients who did not get Olaparib. And then at 48 months, that's still holding pretty steady. Again, giving us some hope that we may have cured some patients here. This looks very similar to every other PARP inhibitor in terms of side effects. So I wanted to put this one up. We see a lot of nausea with PARP inhibitors, all of them, but it's very low grade, grade 1, and it gets better over time. So it's there, and we have to counsel patients about it carefully, but it is something that's very manageable, as is the fatigue. It's very common, but it's very low grade. So patients can still do things for the most part, but we have to just counsel patients ahead of time that about what to expect. Really, the only hematologic toxicity we see of note is some anemia in about 20% of patients, which again, we can adjust for. So that's just right now for patients with BRCA mutation. So what about everybody else? There's 3 studies set to result this year, probably maybe at ASCO, which is in June, but probably at ESMO, which is October. So these are things to watch for. This is the VELIA trial, which enrolled high-grade serous and high-grade endometrioid patients. You could have a BRCA mutation, but you also could be BRCA wild type, and it randomized to Taxol Carbo, Veliparib, which is a PARP inhibitor, and Veliparib maintenance versus Taxol Carbo, placebo maintenance. And patients were randomized and stratified by BRCA status. And this study has been done and maturing actually for over a year. So you couldn't do this study now because you would never randomize a patient with a BRCA mutation to not get a PARP inhibitor. But this was done, actually it finished in 2017. So we'll see, really, it'll be interesting to see how the non-BRCA patients do on this study. Then there's PAOLA-1. This is a European study. Again, should result out at ESMO, which is the European big meeting in October, where they took patients with advanced stage disease. In Europe, the standard of care has always been, or has been for many years, chemo plus bevacizumab and bevacizumab maintenance. So everybody got that. And then they randomized to bevacizumab plus Olaparib maintenance or bevacizumab plus placebo maintenance. Again, BRCA patients are on this study, so we have a lot of BRCA patients who did not get a PARP inhibitor for maintenance, but this study was done long before the SOLO-1 results came out. So we're really going to be looking at the non-BRCA patients to see how they did with Olaparib added to their bevacizumab. And then finally, the PRIMA study is a U.S. study, actually it's U.S. and European, where they took, again, all patients who had a good response to chemotherapy, and they were randomized to Niraparib or placebo. And again, there's BRCA patients on this as well, but the majority are not BRCA patients. So these three studies, I bet you are going to be positive. We'll see how positive they are. Are they monumentally positive? Or are they just a smidgen positive? And that will determine whether or not we start using PARP inhibitor maintenance for patients, just everybody, and not just BRCA patients. So the standard of care may change at the end of 2019. We're all pretty excited for these studies to result. And these are just an overview of the studies that we're kind of waiting on that we just talked about. So I can skip over that. And then the other big question is immunotherapy. Should we be adding immunotherapy to PARP inhibitors, or to frontline therapy? There's a lot of rationale for doing this. Ovarian cancer is very immunogenic under the microscope. So it should be very responsive to immune checkpoint inhibitors like Keytruda, which is pembrolizumab, or Opdivo, which is nivolumab. When we've used those drugs in the recurrent setting as single agents, they've been really just modestly active, 15% response rates. Little disappointing, but it may be because we're waiting too long to use them. So we've moved them into frontline. And so there are studies ongoing right now. There's one called Imagine-050, which is combining immunotherapy and bevacizumab versus bevacizumab in the frontline. So that will be exciting to know. So we're waiting on those sorts of studies. And then we're combining everything together, so immunotherapy and PARP inhibitors. There's a lot of rationale for doing that preclinically, and we actually have evidence in recurrent disease that it works pretty well. And so all of these studies have recently launched. They're all very new, just starting to enroll patients, and they're slight variations from one another, but they're all asking the question of, should you add a PARP inhibitor plus immunotherapy plus bevacizumab, or just need two in some of them? So they're kind of asking the question, if we throw the kitchen sink at patients, will we cure more people, which would make it worth it? So these are all ongoing. So it's a pretty exciting time right now with the number of new assets that we're trying to evaluate in frontline ovarian cancer and see if we can do better in a non-BRCA population. So we need to do as better as we did in SOLO-1 for them. So it's very crowded right now. There's a lot of studies that are resulting and that are launching. Lots of opportunities for our patients who have new diagnoses to get access to very novel therapies, which is really the best way to take care of somebody. So I hope people are asking about clinical trials so we can get these accrued and see if this is how we should be using these drugs. I mean, there's lots of questions about whether or not this is the right thing to be doing. So it's a crowded landscape, but it's pretty exciting. I told you about the studies that are going to result this year. Those in the middle in pink. And then 2 recurrent studies will be resulting at ASCO. You'll hear about these. So a lot coming, which I hope will be positive and good news for our patients. And with that, I think I'll stop and answer questions, if that's okay.
Super, great. Thank you. I'm going to change the presenter back to me. And that was just packed with info. So yes, and we have lots of questions. I want to remind folks that you can still submit questions. So on the right-hand side of your screen, there should be a GoToWebinar pane there, and there's a little drop-down that says questions. Click on that, type in your question, press enter, and I'll be taking those. You can see just my slide, not my question pane, right, Dr. Moore?
I can see the teal screen that says questions.
Super, super. Okay. So first question is, can the SOLO-1 trial data be extrapolated to other PARP inhibitors?
I think it can, to be honest. We really think, if you look at the platinum-sensitive recurrent studies and in the BRCA cohorts, those hazard ratios are all very, very similar. So in a BRCA population, we don't really think there's a big difference in efficacy between the 3 PARP inhibitors. So, I don't know why someone would want to use one versus the other. I just use whichever one I can. I guess it comes down to finances. Sometimes the copays are different. So if one's going to be super expensive, one's going to be cheaper, it wouldn't bother me to use a different one. I think the benefit's going to be the same.
Okay. Some people are asking about how do physicians decide which PARP to use or to use a PARP. Is there a certain formula or guidelines or certain criteria that they follow?
When picking the PARPs?
Yeah, or when deciding which PARP, deciding to give a PARP at all.
Yeah, there's, I think it's very individualized. In the frontline setting, as I said, if you have a BRCA mutation, that's the ideal time to give it, because hopefully we've cured some more patients. I mean, that's the hope here. So and the magnitude of benefit in using it first rather than waiting for someone to recur and then using it, like there's just no difference there's no comparison. The best time to use a PARP is frontline maintenance for patients that have BRCA. I think that has been established, put a fork in it. So and I will argue with anyone in any day about that. In the recurrent setting, in someone that has not yet seen a PARP, and we're going to enter an era where people are going to have seen PARPs, so we're going to have to figure that out. But in a recurrent setting where someone has not seen a PARP and they have disease that could still be treated with a platinum, then the question is, do you use Bevacizumab or do you use a PARP inhibitor? And that's an area where there's just a lot of what we call clinical equipoise, where providers sort of have their biases. I think, again, if you have a BRCA mutation, either a tumor BRCA or germline BRCA, and you have not yet seen a PARP, then I think that's a no-brainer. You do chemo, and then you do switch maintenance to PARP. If you do not have a BRCA mutation, then I think it's less clear which agent provides the most benefit in terms of length of time to next recurrence, either PARP or Bevacizumab. From a purely pragmatic standpoint, if you don't have a BRCA mutation, at least as of the indications right now, the only way you can get a PARP inhibitor is in that setting of platinum-sensitive maintenance. And if you don't use it at the first opportunity there, and you say, well, I'm going to use Bevacizumab first, and then the next time she recurs, I'll use platinum again, and then use a PARP. But you're gambling that A, your patient will be platinum sensitive again, and that B, she'll respond to platinum, and you can use that PARP inhibitor. And so you may lose the opportunity to use a PARP, whereas Bevacizumab you can use in many lines of therapy. So from a purely pragmatic standpoint, if I think someone has a chance of responding to a PARP inhibitor, and I do a lot of molecular profiling on my patients to try and help me have the most information, then I'm going to use a PARP earlier. But I wouldn't, again, that's not one that I would fall on the sword for like I would frontline. Like, I think there's room for individualization there. In terms of which PARP to pick, they're all very good. They're really all good drugs, and they work, we think, equally as well. I think it comes down to provider comfort. some providers got really comfortable with Olaparib, some providers got really comfortable with Niraparib or Rucaparib, and they feel really good about the dose modifications and how to counsel their patients. And so that's really, I think, the most important thing is your doctor being comfortable with the drugs that they're providing so that they can monitor you appropriately. Other than that, again, sometimes it comes down to cost and copay programs. Like I'm in Oklahoma, I don't take care of a lot of patients with a lot of money who can afford $1,000 copay. So I'm going to use whichever PARP they don't have to pay for. So sometimes it comes down to that. I mean, it's really comes down to just sometimes really basic things.
Yeah. And well, I'm glad you brought that up. That was that was one of the questions. I mean, actually, the most common question we got was, if I am not a BRCA patient, what are my considerations? And you sort of went into that. So they can still talk to their oncologist about it, and hopefully maybe they should be talking to a gynecologic oncologist who might be more familiar with these drugs. So have you heard about cost being a problem for folks? That was one that was also asked.
I have. I mean, I've certainly had experience where, I just had somebody who just could not, she made too much to qualify for full coverage, and the copay was just still ridiculous, like $2,000. And so we just couldn't use the drug. I eventually got it for her on a clinical trial, so it ended up being okay. But I have had that happen. But that was early on, and I think that I haven't had it happen as much recently. I think the companies are doing a really good job of, in my mind, and again, I don't take care of patients that can just pay out of pocket for these drugs. I haven't gotten a lot of pushback on finances recently, so I think the companies have really good patient assistant programs in place that help fill that gap for our patients. But I do think cost is always an issue. And even if you can afford it, like, why is it right that you're paying thousands of dollars a month? Like, that just adds to financial toxicity, even if you are making enough. So, I mean, I think it is a problem. I don't have a solution for it other than I use a lot of clinical trials, and then they get it for free.
Right. Okay. Actually, a couple people were asking, I think, in reaction to something you had mentioned about future study, about combinations with PARP. So whether you're BRCA or not BRCA, are there combinations of PARP with something else that is FDA approved or in trial phases right now?
So nothing FDA approved yet for combos, but there are things that are in clinical trials. And I think the combinations is really where we're trying to get at that, the kind of PARP resistance. So patients that don't have a BRCA mutation and aren't inherently sensitive to PARP, but if you combine it with something that's synergistic, can you get people to respond? And so we do see that. We do see some evidence for that with combinations of PARP and immunotherapy. So there's a study called Topacio, which should be coming out in publication very soon, that was Niraparib and Pembrolizumab, which is called Keytruda. You're placing the commercials. And that was in patients with triple-negative breast cancer and recurrent ovary cancer who were resistant to platinum. And they had a pretty nice response rate. It was about 27%, which is good in a resistant population. And that response rate was irrespective of BRCA status. So if you're a BRCA patient, you had 27%. If you were a non-BRCA patient, you had 27%. So the response rate seemed to be agnostic of biomarker status. So that gives us some idea that the two together, may overcome whatever resistance to PARP inhibitor alone that someone who doesn't have a BRCA mutation may have. So that's kind of one. And it's a smallish study, but that's one idea. And there have been a couple other immunotherapy PARP small studies that show some modest efficacy. So that's one area, and kind of why in the frontline studies you see a lot of combinations, the ones that have just started, with immunotherapy plus PARP inhibitors. Almost all of them have that. So that's one. There's immunotherapy plus, anti-angiogenic agents like Bevacizumab. They play well in the sandbox together, but probably aren't overly synergistic. They just may work better together. And then immunotherapy plus angiogenic agents seems to be very synergistic. So I think there's some early data with PI3 kinase inhibitors, which is a targeted therapy that looks very interesting in combination with PARP inhibitors. Those results just came out by Dr. Konstantinopoulos out of Dana-Farber and Cell. So pretty exciting, but very new. So those studies are just launching, kind of early phase studies. So I think we're still looking at combos. There's some very interesting things out there. Shannon Weston at MD Anderson has some PARP, AKT and PARP PI3 kinase pathway combination trials that she presented at ASCO last year that had a nice signal early, though. I think not anything that's on the verge of FDA approval yet.
Okay, so we're almost out of time, so I have two really quick questions. First one is, what do you recommend to your patients in terms of genetic testing?
Everybody needs to be offered genetic testing. Now, some patients may opt to not get it, and that's, again, shared decision-making. Patients are autonomous beings, and they can make decisions. But they have got to be offered the opportunity to get tested. I think just people aren't offered. And I have very few patients that don't want to be tested. So they need to be tested. It impacts their therapy now, and it definitely impacts the health of their families. And I mean, almost all of my patients care about that. They don't want their kids having to deal with this. So if we can prevent it, I mean, put us out of business. That's what we all say that. We're all smart doctors. This went out of business, I would find something else to do. I mean, we should be preventing. If we tested everybody, did appropriate cascade testing, we would almost instantaneously reduce the incidence of ovarian cancer in the U.S. by 20%.
Wow.
So that's very meaningful, and we're not doing it. So we have a lot of work to do. So patients need to be their own advocates, and if they are not tested, they have got to, and they want to be tested, they've got to get tested. And there's lots of places they can do that. Even if their provider isn't comfortable doing that, they can see a geneticist at any of the academic centers who will be happy to test them. And it's covered, like insurance pays for it. And all this worry about it being in their insurance and then they don't get life insurance, like that has not panned out. So there's just no reason to not get tested. It's just too important. Yeah.
Okay. One final question. What is the length of time people are put on a PARP? Say Frontline and BRCA folks. And
Frontline. So Frontline and Solo 1, it was 2 years. And we don't have time to talk about why you picked 2 years. It wasn't entirely arbitrary. It was a little bit, but not entirely. And I don't know if it needed to be 2 years or maybe it should be 3 years. Like, we just don't know.
Okay.
The studies that are ongoing, though, like Prima, which is an all-comers, that's 3 years. So we're going to have some data on longer follow-up, but right now 2 years. Frontline. Okay. In the recurrent setting for maintenance, we use it until progression. So you can have patients on, and there's older studies where patients are still on 5 and 7 years later. As long as they're disease-free, we're going to leave them on. So in the recurrent setting, where a repeat recurrence is almost guaranteed, you keep someone on a PARP inhibitor until you have to take them off. So we would continue that.
Okay, great.
Hopefully forever.
So I wanted to say thank you so much. This has been packed full of really good information. This presentation has been recorded, and so I will be emailing the presentation, the video, out to everybody who registered. Also, Dr. Moore, if you could share your slides, we'll email those out to people. And I put up a couple upcoming educational programs we have, so you can check those out on sharecancersupport.org. please take a moment to fill out the survey at the end of the webinar. It may take a minute for it to download, but please fill it out. These surveys help us create better programming for our ovarian cancer patients that we serve. So thank you again so much, Dr. Moore, and thank you to everybody who submitted questions.
You're welcome. Hope it was helpful.
Yeah. All right. Thanks.
Bye.
Bye.